Cancer screenings are one of the best tools in the fight against cancer. And that's why Optum is a proud partner of Cancer Screen Week, taking place December 6th through the 10th. Prioritize your health and see what screenings are right for you. Take the pledge to get screened and learn more. Visit takeahealthystand.org to learn more. That's takeahealthystand.org.
Welcome to the FUMS Now podcast show, where you'll gain information, inspiration, and motivation for living your best life with multiple sclerosis. Find us online at FUMSnow.com. I'm your host, Kathy Reagan Young. Hello, everyone. Thanks for coming back for another episode of the FUMS podcast show. Just a quick reminder, there are resources and show notes and MS holiday gift guides and a blog post and FUMS merchandise shop, all available over on the FUMS website. I invite you to check it all out at FUMSnow.com. Today's guest is Dr. Rhonda Voskuhl. She's a physician, research scientist, and professor in the Department of Neurology at UCLA. She also holds the Skirball Chair and is the director of the MS Program at UCLA. Today, she's sharing with us her work on sex differences in MS. Welcome, Dr. Voskuhl. Thanks so much for being here today. Really appreciate it.
Well, thank you so much for having me.
So I'm so interested. I've listened to several interviews of yours in the past, and it's fascinating to me. But let me start at the beginning. How did you become, interested in researching sex differences in MS? And if you don't mind, just quickly, I've heard you refer to it as sex differences. Is that in any way different from gender differences, or are the terms interchangeable?
They're not interchangeable.
Okay.
So sex differences refers to, generally it's aligned with the NIH priority of studying sex as a biologic variable. And that is, a biologic variable is female versus male. And generally that involves, female sex hormones, sex chromosomes, and male sex hormones, sex chromosomes. So estrogen, XX, testosterone, XY. Gender is different. Gender is more of a perception of how one sees themselves, the life that they live. And this can be very impacted by environmental factors and choices, whether it's increased risk related to smoking or work habits or all kinds of factors that you can imagine, and that you can have an interaction with each other, so they're not mutually exclusive.
Okay. So what brought you, thank you for that definition, by the way, that was very helpful. How did you become interested in researching the sex differences in MS?
I became interested in it because I think that when one tries to discover novel inroads into any disease, it's actually de-risked if one bases the foundation on a clinical observation. So I call it bedside to bedside, as opposed to say bench to bedside. So something laboratory bench that then you translate to say a clinical trial. What I try to do is I try to start even further back and base even the laboratory bench work on the bedside. And by that, I mean the bedside, I mean like observations such as, females are more susceptible than males are to MS or other autoimmune diseases, or maybe males are now appearing to do worse with respect to neurodegeneration. So I think that the way to really make an inroad into some of the MS specifically is to pay attention to these things that patients know and doctors actually know, and to ask why. And because if you could figure out why, you could either, expand the things that are good, or obviously reverse things that are bad that are naturally occurring and everybody knows are present. Otherwise, you could end up doing a whole lot of work in the lab that wouldn't really be that relevant to the human condition or to MS patients. And that's of course, exactly what you don't want to do. It's got to be all about the patients and trying to figure out why things are the way they are at the molecular level, at the genetic level, and so forth. And then taking that back out to them, hopefully in a trial that harnesses, the good things or the bad things in the way we would like for it to be.
Right. Great. You referenced that men fare differently. And I know I've heard you say almost 3 times more women are diagnosed with MS than men. Do we have any idea why?
Yes, that's what I've spent, of course, a very long time working on. And unfortunately, other people have started doing so as well. So we have made many inroads into that. So to really kind of repeat the specifics of it, it's interesting because while women are 3 times more likely to have MS, they're more susceptible to getting this autoimmune disease. It's interesting that when men do get it, they tend to do worse. And with regard to what? And it's with regard to disability accumulation. And so, as most of this audience probably knows, MS is a complicated disease. It's an autoimmune disease where the immune cells go in and they target the brain and spinal cord with these inflammatory sclerotic lesions. But then that also leads to this long-term disability accumulation. So not just relapses and remissions, but also this accumulation of chronic disability that doesn't go away. And that's the big holy grail right now, is to find things to stop that or heal that. But it's really, I think, that the dichotomy between it's both an autoimmune disease, and again, women tend to have autoimmune diseases more frequently, whether it's lupus, rheumatoid arthritis, et cetera. But then it also has this neurodegenerative component. So you have the immune attack, but then how does the brain or spinal cord respond to that attack? And how does it undergo neurodegeneration? And is that different between females and males? And it is, and it's actually kind of the opposite way. And so you really think about sex differences in the immune system and sex differences in the brain, to put it. And they don't necessarily go the same way. One can be, beneficial. Actually, in this sense, it seems like females have a more robust immune response. They respond more dramatically with respect to the types of immunity and the level of immunity. But it may very well be that their brains are a little bit more resilient to damage, and they can repair a little better. So that's the way it's looking.
Yeah. Interesting stuff. I noticed and have heard from other women with MS that, for instance, when I was pregnant, I felt fantastic. And I've always said, if it didn't result in another child, I could be pregnant for the rest of my life. I felt that good. So this certainly seems like a nod to estrogen to me. Is that where this type of research began? Like it did, with women reporting that they're feeling better in pregnancy?
Yeah. So there are when you start to think about sex differences, you think about whether estrogen is good or bad, or testosterone is good or bad, or you think about XX, the chromosomes are good or bad, or XY good or bad, right? So you have to be very broad in thinking about these things. And there does seem to be a role for sex chromosome effects that could be playing a role in the immune system or in the brain that I could talk about more. But also then you think about sex hormones, which you just referred to. Now, in pregnancy, I do like to make this distinction, though, because pregnancy is not the usual estrogen, progesterone cycling going up and down, every month, as we all know that it does. At very low levels, it cycles up and down. There's a big difference between that estrogen and the estrogen of pregnancy. So with pregnancy, we've actually discovered a unique estrogen of pregnancy called estriol. And estriol is made by the fetal placental unit. It's not made normally during menstrual cycles. Women don't have it when they're not pregnant, but when they get pregnant, there is, it used to be followed actually for viability of the fetus before ultrasounds came about, because it'll get higher and higher and higher with a viable fetus, as pregnancy goes on. And so it's high at mid-pregnancy. It's a very high third trimester. And then after you deliver the baby, of course, it drops abruptly because the fetus is gone and it's what's making it. And so it drops abruptly. And as we know with MS too, the other observation is not only do relapses decrease dramatically by about 70%, so as good as any drug that we have. Right. But again, it's the last half/third trimester. That's when estriol is very high. And then, as we also know, after people deliver, about 3 to 6 months later, they have increased risk for postpartum relapse. And so could it be that sudden dearth of it, the withdrawal? Yeah, that could play. And these things don't happen overnight. So you change something, it takes about 3 to 6 months for things to actually play out through all the effects on the immune system and the brain. So yeah, I think that there's sex differences. And there are things like pregnancy that happens to happen in one sex, of course, and doesn't happen in the other. But they're kind of two different things, but they certainly do suggest a role for estrogen. And we've looked at that a lot. We've done 3 clinical trials with estriol, and we've shown anti-inflammatory effects. And what's pretty cool, too, is we've shown neuroprotective effects with the estriol. Both in the MS model and in MS patients, we had shown sparing of brain atrophy, cortical atrophy, and improvement in cognition. So some really neat things with estrogen and neuroprotection. I think one of the things I always like to do also is to bring it out to the larger scope of things. And that is it just that I'm that lucky that I would be studying something that happens to be both anti-inflammatory and neuroprotective, which is, of course, exactly what MS patients need because they have too much inflammation. They need neuroprotection. So am I just that lucky or what? And I think I may be lucky, but I think it's a little more than that. I think it's all about the baby. So, it makes most sense. The baby is actually half foreign. It's got half the father's proteins and genes on it, of course, and it would be rejected as a transplant, but it's not because the maternal immune system is known to shift away from these kind of immune responses that would reject the fetus. And so there's evolutionary pressure to select 4 women who can shift their immune systems away from these cellular infiltrating to more of an antibody producing immune system. So it shifts to accommodate the baby, what's good for the baby so that it can survive and do well. And if you think about it, I was just thinking about that. Well, why this neuroprotection? I thought, well, actually it kind of makes sense because the other thing that's really most important for the fetal survival is that if any kind of infection or hypoxic event, low oxygen, any kind of an insult, injury to the mother, you really want to make sure that the baby's developing brain and spinal cord survive because if you have an injury, that's, of course, the worst thing that could ever happen for fetal survival.
I'm so sorry.
That's okay. This is, a good thing. Dogs are a good thing. But anyway,
she's my medicine.
Yeah, there we go. So I think that it just makes sense that the mother's body would have a circulating hormone such as estradiol that could be both anti-inflammatory and neuroprotective for that developing immune system, for the developing baby to survive any possible immune attack or actually to preserve the developing nervous system.
Yeah.
So it just so happens for mothers with MS, that's the best thing they could have, right? Would be anti-inflammatory and neuroprotective.
Right. Yeah. I really, again, just want to reiterate how great I felt. I mean, I've just felt phenomenal. And then to your earlier point, at right about the 6-month mark, I just tanked and felt horrible. I had not yet been diagnosed, so I did not know that I had MS. So this is looking back, but oh my God. And I went to every kind of doctor imaginable trying to figure this thing out. And I did have one doctor who said to me, well, I think it's that your pregnancy hormones dropped.
Yeah. Well, you'd be surprised how many women actually, quote unquote, get MS, for the first time, and it's actually postpartum. Oftentimes that's the first, because I just think it's just such an inflammatory situation when you have this sudden drop in these protective factors. Yeah. And it kind of is probably right on the balance or the edge all along. But then when you have this is what happens. So
it's very pronounced. The difference that you feel for sure. So that brings me to menopause and MS. If, sort of my definition of menopause is, this estrogen drop. It drops, it's abrupt, right? Typically right around 50 or so. And there's, more brain atrophy and cog fog and issues with processing speed oftentimes. And this has been my personal experience as well. Do women with MS who are on hormone replacement therapy fare better?
Okay, so this is a really important point that you're bringing up. And what's known is that your experience is like most, and that is during menopause, what happens to MS patients is they say that their symptoms get worse. And this has been known for actually quite a long time in small studies. And now it's being confirmed with some objective measures, such as disability measures and brain atrophy measures. Like you said, certain, not it's not the whole brain, it's certain parts of the brain. And so I think it's important to distinguish that from relapses. So what doesn't happen during during menopause in MS patients is that they don't start having relapses, right? That's not what happens. What happens is their pre-existing MS symptoms tend to get worse. And so to me, this sounds like it's not necessarily related to any kind of it's not related to the anti-inflammatory effect, which we've actually done experiments showing that I don't think the cycling levels of estrogen and progesterone during the menstrual cycle make that big of a difference on the inflammatory component. But I do think that they can have a role on the neuroprotective component. And that's because now we do have quite a bit of data starting to accumulate that when MS patients, like I said, when they go through menopause, again, not have an increased relapses, what they have is they have pre-existing symptoms getting worse, which sounds like neurodegeneration and sounds like disability accumulation, right? So we're at that other spectrum. So to that end, your question is obviously a good one, and that is, does HRT help? Well, what is HRT? HRT is generally Premarin, which is pregnant male urine protein. That's why it's named that way. It's a lot of different estrogens, but it's based principally on estradiol. Estradiol is also another form of HRT, which is it's the standard estrogen that's there during the menstrual cycle. But the problem with the short answer is no, HRT doesn't help. And I can tell you why I think that is. I think it's because you can never treat with estradiol or with estradiol containing molecules to the point of a pregnancy point. Let's put it that way. So estrogens are they can be very protective. They can be neuroprotective, but it depends on the type of estrogen. It depends on the dose of estrogen and the timing of the estrogen. So just like this is true with interferons. For the MS community, this is nothing new. So we all know with interferons, beta interferon works. Guess what? Gamma interferon doesn't. We know that higher doses like Rebif are more strong than Avonex. I mean, we know the timing matters. So you've got to treat at a certain time point in the MS. So this is all true for estrogen. And it's not going to be that easy that you can go grab Premarin off the shelf and think that that's going to help the MS. It's not. I don't think it will. And I don't think it will, because if you look at the menopausal women who do not have MS, they have what you said. It's called brain fog. It's so common. It's called brain fog. And that is a cognitive problem. It's not global cognition. It's not IQ. It's not any of those things. What it is, it's very specific things. And to be, namely what it is, it's verbal memory and it's processing speed. So these are very domain specific. They're very region specific in the brain where that mediates these problems. And this is what happens during menopause. So my goal is to treat with estriol. And the reason I want estriol instead of estradiol or Premarin is because you can give estriol binds to ER. It's a little complicated, but not that much. It binds to ER beta over ER alpha. So ER alpha is the one that's in breast. ER alpha is the one that mediates the deleterious effects of estrogens. And that's why there's a big controversy about whether HRT should even be given, right?
Right. Especially if you have a family background of breast cancer, right?
Right. And so the key element, like actually most drugs, what people do is they tailor them to the receptor that can still provide some efficacy for what you're interested in and not have the toxicity. And that's why we're interested in estriol. The other reason we love estriol is that's the naturally occurring estrogen of pregnancy. That's the one that we know is protective. We know that it helps women who are pregnant do better. And so we're trying not to deviate from the natural situation that we know is beneficial. And that is an estriol is the main pregnancy. The dose has got to be a pregnancy level and so forth. So I think, again, I don't think science and trials are that easy where you can say, well, Premarin's on the shelf and people have used it before for hot flashes. So this is going to work to be neuroprotective.
If only.
But again, the beauty of it is we can do like and we should do what's been done with, for example, the interferons and some of these CYP1 receptor modifiers. There's all kinds of drugs in MS that get optimized for the receptor and the type that it should be used to do specific things. And we can do that, with estriol. We can actually, and so we are designing a trial to give estriol to menopausal women with MS. And we think we know what the outcome measure should be. It shouldn't be anything to do with relapses, honestly, because that's not the problem with menopausal women with MS. It should be related to sparing brain atrophy in a certain region, not necessarily global brain atrophy. It should be improving cognition in these very specific domains that they have a problem with, not all of cognition, because that's not a problem. So I think that it's really exciting because we've made so many inroads. You have to really understand these things in a specific way to go out and target them optimally.
Yeah. The doors to the Patients Getting Paid membership community are now wide open. This is a community of people with chronic illness learning to find and create flexible remote work that accommodates their health. I call us chronicpreneurs. There are trainings, coaching calls, networking opportunities, co-workings, and a ton of resources. Want to take better care of yourself and still generate an income? Join us at patientsgettingpaid.com. What about postmenopausal women? Is there a difference? Do you see their cognition come back, or are we?
No. So I think that,
damn it.
I mean, I think that the hot flashes go away. Most people know that, but I've never heard of the cognition just, coming back.
Mm-hmm.
I think that it's important to do these things now, because I think that the key will be to treat women when they are between, 50 to 65. I think, unfortunately, I think that women who, there have been studies in Alzheimer's disease, for example, the same kind of things, that estrogens can be beneficial for Alzheimer's disease, but then they didn't treat women who were young enough. They treated them when they were 75 or 70, and it's probably you're going to be less efficacious. It could be more toxic. They also didn't use estriol. They used Premarin. And so there are a lot of issues. So again, the timing matters, and it should be preventative. It should be, you should be treating menopause when it starts, and you should be continuing it, treat within 5 to 10 years of it starting, and you shouldn't let these bad things happen. It's kind of like the MS drugs,
Yes.
It's hard, if you don't start the treatment early and you get on it ahead of time, then it's very difficult to try to reverse and repair all these things. Although I do think there is some evidence that estrogens can be reparative. It's called synaptic plasticity. Synapses are the connections between the neurons, and there's evidence in a lot of models that estrogens can regulate synapses and make new ones form. And so I was really pleased when we gave estriol and we saw an improvement in cognition. So it wasn't just a slowing of the decline, which you see with the Alzheimer's drugs. Okay, they work, but how do they work? Well, they slow. They get worse. People still get worse. They get worse at a slow rate. That's really not that exciting to me. Mm-hmm. I think what's really cool is we actually saw some improvement in, so that's really exciting. And that to me implies some sort of repair. It could be remyelination. It could be synaptic plasticity, making more connections. It could be, the myelin is, of course, the rubber around the wire that keeps the conduction going. So estriol, ER beta ligands, that particular ER beta targeting of estrogens is really exciting, I think, for repair.
Oh, that is exciting. How do I ask this? Is there any way that you suggest women with MS can prepare themselves and their bodies, perhaps in a different way, for menopause? Is there anything to be done, like in the run-up?
Yeah, I think that one of the best things that can be done is exercise. I think physical exercise, it releases molecules that can be neuroprotective. It's thought, this hasn't been as well studied as estrogen. I'm not saying that it has, but there is some evidence that, estrogen, the exercise can be good for the brain and cognition. I think that cognitive exercise, that would be some games and, just doing those cognitive challenging things that come with our jobs. And so for a lot of social interaction, just conversations can be really interesting and intriguing ways also to stimulate the brain. I think those are good things. Reading, I think physical and cognitive exercise, and actually I believe, and I won't say I have evidence for this other than some basic science that suggests it, but we haven't done trials in it, but I would love to see, taking estriol and doing the cognitive and physical exercise, because I think this is ideal. I think you're trying to push your system to do these cognitive and things, and then you're taking the hormone to help as you're to do those things. And I think that's the ultimate way to improve.
Yeah. Well, that makes sense to me. Now, I know all this is, in research stages and whatnot, but could I just go to my gynecologist and ask to be prescribed estriol? I know it's obviously off label, but I mean, if I believe in your research, and I do, everything you just said makes a lot of sense to me.
It can be done off label. We have to realize, like anything that's taken off label, it's been through 2 phase 2 trials, a third one, a trial. We haven't been able to do the big phase 3 trials, primarily because estriol is inexpensive. And it's hard to get drug companies to really put a lot of money into things, really hundreds of millions of dollars in marketing and all this stuff, TV ads. I mean, when they can only charge a certain amount of money at the end of the day, it wouldn't be covered by insurance if it's off label. You still would have to take a progesterone with it, like any estrogen, whether it's in a birth control pill or whether it's HRT. Women always take a progesterone with an estrogen, and we've done that. But you could take a standard dose that's used for example, for estradiol, would be plenty protective. With estradiol is much more likely actually to cause uterine endometrial hyperplasia. That's why we take progesterone, so you don't take unopposed estrogens. And so that's routinely done to give a progesterone with an estrogen. And I would suggest taking estriol and taking a dose we've actually used for MS patients, and is still taking that same progesterone in combination with it to prevent not taking unopposed estrogens like you would with the estrogen, just to be totally safe. But it's a pretty good, actually it's a really good safety window, something that is even safer than, for example, HRT, because, the MS drugs people are taking are certainly, you wouldn't be giving those to healthy people. Like HRT is taken by healthy women.
Right.
And so we're talking about something that's in the safety window of the healthy women's range, which is a really good spot for MS patients to be in, I think.
Yeah, definitely.
Hello there, friends. It's Matthew Zachary, and I'm excited to tell you about a great new podcast called Healthy Communities News, presented by CVS Health. Every month, host Melissa Egan engages one-on-one interviews with community leaders from across the country who are tackling the factors outside of the doctor's office that impact health, wellness, and access to high-quality healthcare for everyone. You'll hear about UNCF's efforts to train more Black doctors, and you'll visit a clinic that has served downtown Houston for more than a century. You'll meet the people who hope to eradicate HIV transmission by 2030 and learn about the pandemic successes of a youth services clinic in Florida. Each episode profiles leaders who refuse to back down to local challenges. Healthy Communities News from CVS Health is available wherever you find new podcasts. New episodes appear every month and are available in both audio and video formats. Subscribe, listen, and enjoy today. Did you know that more than 1/3 of people living in the U.S. have missed routine cancer screenings due to COVID-19? Well, Optum is proud to support Cancer Screen Week this December 6th through the 10th. If you've missed or delayed your cancer screenings, talk to a doctor or your primary care provider about what screenings are right for you, and take the pledge to get screened. Visit takeahealthystand.org to learn more. That's takeahealthystand.org.
I've kind of leaned into the women's side of things, but you did mention men tend to fare worse with MS, that have worse disability and progression. Any idea on why that may be?
Yeah, so I actually believe that, not just believe, but there's a lot of evidence that, let's put it this way, that estrogens and testosterone can do the same things, and that's because testosterone is converted to estrogen in the brain. So there's an enzyme that converts testosterone to estrogen in the brain, and so testosterone can be neuroprotective.
Yeah.
By getting converted to estrogen and then binding these estrogen receptors to confer protection. So then the question is, well, why would there be a difference in men versus women? And so I've made a graph that I presented it at some meetings, and I plan on publishing it soon. I haven't had time to write it up yet, but I think that what you can see is that testosterone declines actually in MS in men in all men from age 30 to 80. It's very gradual. Andropause is gradual from age 30 to 80. It's 1% per year over a very long period of time, right? Women, in contrast, when they have menopause, they do actually really well. The estrogen stays high up until age 50 to 52 or whatever. And then, of course, it drops abruptly and it's gone. Now, let's think about that. So that means that there's an age that's about 35 to 50 where women are actually doing pretty good. They have estrogen. It's not dropped, but men have actually had this drop. And actually, most of the MS studies that show the men are worse, the average age of those studies, the men are about 42, 40, 41, 42, 45. So they're actually suffering a little bit from that low testosterone, and women are doing fine.
Mm-hmm.
And then you can imagine, of course, the women are going to catch up and surpass them after menopause. Then things are going to go really bad for women. And we actually, other people have studied this, and we have too, about men with MS. So men with MS tend to have low testosterone levels compared to men without MS. They live in kind of the low normal range. There's a wide range of normal for testosterone. It goes all the way from 300 to 900 is the range in the blood. And that varies by age. It varies by time of the day, a lot of things. But the bottom line is MS men, as compared to healthy men, tend to live in that low normal range.
Mm-hmm.
And the other thing is that men with MS those that have lower testosterone levels compared to men with MS who happen to have somewhat of a higher mid-range, the ones that have lower levels tend to do worse on cognitive testing the next couple of years, on other markers of disability. Mm-hmm. And so that's consistent with these low levels of testosterone in men not being a good thing.
Yeah.
And so we did a trial, it was just a very small trial, a pilot trial. We gave androgel to men with MS, only 10 patients. We studied them with an MRI every month for 18 months, 6 months pre-testosterone and 12 months on testosterone. And we showed that it slowed their brain atrophy, which is pretty cool.
Yeah.
And consistent with testosterone being protective in MS. So more studies need to be done of testosterone in men with MS.
Yeah.
And just like studies need to be done of the right estrogen time dose and timing with menopausal women. I think the menopausal women is a lower hanging fruit because it's so abrupt. It happens so rapidly. You can do a trial in a few years. With men, it's going to be hard. It's such a slow decline. I think it'll be a little bit harder to design, but theoretically, I think, scientifically, it should be done.
Yeah. Very interesting stuff. So I'm going to put two things together here and ask if this makes sense. It makes sense to me. There are discussions, I know one of my neurologists mentioned this, of removing people from DMTs, like I guess between 60 and 65, right? But it seems to me that that's when we need neuroprotection more. I mean, we as a people, not just we as people with MS. So what do you think about that? And is there something else that maybe we would replace the DMTs with?
Right. The problem with the DMTs that we have is they're all targeting the immune system. So they've all been designed and geared towards targeting T lymphocytes, B lymphocytes, migration of these lymphocytes, the things that these lymphocytes make. They're all targeting the immune system, and they've been very, very good at reducing relapses. And of course, the relapsing remitting phase generally occurs between the ages of 18 and 50. And so that's why they're very good at reducing relapses, and people should definitely take them. The problem with them is they've not been designed or targeted for the brain or the cells in the brain. They've not been targeted for repair or neuroprotection. Now, of course, it is a good thing to have less immune attacks. That's a good thing. Mm-hmm. But that doesn't mean by just reducing the immune response in the peripheral blood and the number of attacks you get or the number of cells getting into the brain, that's not the same thing as real neuroprotection. Neuroprotection is targeting cells that you've probably heard of, oligodendrocytes for remyelination, neurons for synapses, glia, which is microglia or astrocytes. There's these glia cells that are important in neurodegeneration and neuroprotection. So we don't have treatments that are, by my definition, directly neuroprotective, and that's what we're actually working on. The program that I run is entirely focused now on neuroprotection because we don't have treatments that are neuroprotective. And so the argument that people have when people get to be 60 or 65 is that by that time they're really at this phase of their MS where it's not that really. They're not having relapses every year or two. They're not having a lot of inflammation if you look at gadolinium-enhancing lesions on MRI. And so since all the treatments we have are targeting the immune system, the relapses, the enhancing lesions, and so forth, why are we still having them on them when they do carry a burden? They are expensive. They have some toxicities. They're IV infusions. So why are we doing this to people when they're 65? That's the question, right? Because they're not neuroprotective. So my answer is I have to put on my clinical hat, and that is, well, you have to be careful because you might be surprised. Some people might have really good disease management, and by disease management, I mean relapse management and enhancing lesion management, and they think they're just doing great and they can just quit these things and they're going to be good. That's not necessarily true because sometimes you'll find that these drugs have been working. They are working. When you take them away, some of that stuff does rear its ugly head that you thought was gone, but it actually was controlled is what it was. And so you have to be very careful about stopping these things, but I would recommend people talk to their neurologist in a very heart-to-heart discussion about whether they want to take a trial of doing that or not. They have to be monitored extremely closely because they don't know if they've just kind of grown out of it or aged out of it versus it's still there and just well managed.
Right.
You certainly don't want to take away something. So what would it be replaced with? Well, obviously it needs to be replaced with something that's actually directly neuroprotective, right? Mm-hmm. it's the brain and the brain cells as opposed to just the immune system. And ideally, people should be on both. The majority of the time, people should actually be on both. Even the people that have early MS, they need to be on a neuroprotective treatment, even though it's early stages, because we do know that some of this brain atrophy, it's occurring even early, unfortunately. Even in that early relapsing phase, and clinical isolated syndrome has been shown to have some brain atrophy. So ultimately, like AIDS and like cancer and like all kinds of diseases you can imagine, it's just not a lupus. There's all kinds of diseases where it's not just one treatment. It's not just one approach. You have to have a two-pronged approach. You need an anti-inflammatory, which we now have 15 or 20 of them, but you also are going to need to have a neuroprotective treatment.
Mm-hmm.
Need to both be taken.
Yeah, that would be grand.
So neuroprotection is where we need to focus all the attention. That's what we need to do. And I do think that looking at, sex differences and finding some of these things that can make effects will be, it'll be fruitful.
Yeah, I totally agree. And I'm going to go talk to my gynecologist, as a matter of fact, about estriol. Well, thank you so much for sharing all of this really fascinating information with us today. I appreciate your time in explaining this and your dedicated efforts on our behalf. If people want to learn more about you or your research, where can they go?
Oh boy, just Google my name. I think you'll see more than you care to.
I promise you will, because I Googled her to find her, and there's all kinds of information there. And I will actually put in some ways to find you in the show notes.
I'm just kidding, but you obviously go to my UCLA. I would go through UCLA Department of Neurology, Rhonda Voskuhl, and you'd go to the website for the MS program, and that's the best way to go. And if you want to contribute to our cause, feel free to give online to RMS research at UCLA. We're focused on neuroprotection and trying to, have things for people with progressive MS that really help.
Yes. I mean, this just is, to my mind, where we need to be. And if you have heard this today and you agree, I say I will put a link there on where to donate. And I'm going to donate right after I call my gynecologist.
Awesome.
So thank you so much for being here and all of your help and everything that you're doing on our behalf. We really appreciate it. And take good care of you.
Yeah, thank you. Thank you so much. I appreciate it.
Thank you. Quick shout out to Steve Woodward at podcastingeditor.com for the fantastic work on this podcast, including editing, show notes, and ingenious ideas. If you'd like help with your podcast, whether you're just starting out or an old pro, visit podcastingeditor.com and tell Steve I sent you. Thanks, everybody. I really appreciate you listening to the FUMS podcast show. Be sure to subscribe to it so you won't miss an episode. You can do that right on the website at FUMSnow.com. While you're there, sign up for the free email list so you'll be among the first to know of any new findings in MS research, new therapies and products, as well as any blog posts and podcast episodes I release. Want to chat with others in the FUMS community? Join us on Facebook at FUMS Now. Thanks again, and don't forget to talk to the stupid disease as it deserves. Tell it FUMS every day.
Hello there, friends. It's Matthew Zachary, and I'm really excited to tell you about a fascinating new podcast called Healthy Conversations, hosted by my friend and colleague, Dr. Daniel Kraft, and presented by CVS Health. Every other week, Daniel drives one-on-one interviews with the people who are transforming healthcare in real time: physicians, scientists, technologists, and industry leaders. Let's go beyond COVID-19 to a place where telemedicine and mRNA are nothing more than table stakes. Let's hear about tomorrow's precision oncology treatments, the latest in guided genetic health, and the evolution of value-based care. Maybe the breakthrough research that is redefining functional medicine. You'll hear from the people who are innovating tomorrow's clinical insights today. It's been said that the future is already here. It just hasn't been democratized yet. Healthy Conversations with Dr. Daniel Kraft from CVS Health does just that. It's available for free wherever you get your podcasts. New episodes appear every other week. Subscribe, listen, and learn today.